Here I'm going to discuss the symptoms that arise from either hyper or hypofunctioning of the pituitary gland. So in order to understand this topic, first I would like to discuss the normal physiology of the pituitary gland and then discuss the function of the hormones that are being produced by each part, whether it's the anterior or the posterior part of the pituitary gland. And then after that, understanding of these syndromes would be much easier. So there are two parts to the pituitary gland. The anterior pituitary, which is made of the embryonic oral ectoderm, also known as Rattle's pouch, as well as the posterior pituitary, which is made of the neuroectoderm. Now note that the optic chiasm is in close proximity to the pituitary gland. So therefore, if there is an enlargement of the pituitary gland, like for instance from a pituitary adenoma, therefore it will impinge on the optic chiasm and cause bitemporal hemianopsia. And I will discuss that later on. But for now, let's focus on the hormones that are being produced by the posterior as well as the anterior pituitary. So the hormones of the posterior pituitary are being produced by the neurosecretory cells inside the hypothalamus. And these are being transferred via the neurophysin carrier proteins to the posterior pituitary. And so posterior pituitary, which arises from neuroectoderm, has two types of hormones. The antidiuretic, also known as vasopressin hormone, which increases the water reabsorption. And then the oxytocin, which is required for the secretion of milk, as well as for contraction of the uterus during fetal delivery. The anterior pituitary, on the other hand, has two types of cells. So once we use the hematoxylin and eosin stain, some of these cells are being stained as basophils, while there are others that are being stained as acidophils. So therefore, here I've provided you with a memory aid to know the type of hormones that are being produced by basophils in comparison to acidophils. So the memory aid is called B flat. So the basophils give rise to flat FSH, LH, ACTH, as well as thyroid stimulating hormone. So here we have the follicular stimulating hormone, luteinizing hormone, adenocorticotropic hormone, as well as the thyroid stimulating hormone. Now one other point I would like to mention about these hormones is that the FSH, LH, TSH, as well as the human chorionic gonadotropin, which is being produced by the syncytiotrophoblasts of the placenta, these are all being made of a dimer proteins, and their alpha subunits of all of these hormones is the same. So it's only the beta subunit of these hormones that are different, and so it will confer different functionality for these hormones. But since their alpha subunit is the same, there is sometimes some cross-reactivity between the function of these hormones. For instance, in patients that have molar pregnancy and there is elevated level of human chorionic gonadotropin, this HCG can act on the TSH receptors and cause hyperthyroidism during molar pregnancy. And so therefore, these patients present with tremors. On the other hand, the function of luteinizing hormone is to maintain the corpus luteum in order to continue production of progesterone. Once there is fertilization of the egg and there are syncytiotrophoblasts that are being made of the placenta and there is HCG production, now HCG can take over the function of LH and maintain the corpus luteum. So I'm just letting you know that since these hormones have a similar structure, they're all being made of dimers with the same alpha subunit but differ in their beta subunits, there is sometimes some cross-reactivity. In any case, these were the hormones that were being produced by the anterior pituitary, the basophilic cells, while the anterior pituitary, the acidophilic cells, give rise to two different forms of hormones. The somatotropin, which is known as the growth hormone, as well as the prolactin, which is required for the production of milk. So prolactin will produce milk, while the oxytocin will act on the myoepithelial cells to induce secretion of milk. Alright, now with this information in mind, now we can go ahead and review the function of every one of these hormones and the symptoms that arise from their defects. So the first hormones are gonadotropins, the follicular stimulating hormone, as well as the luteinizing hormones, which are required for the production of the sex hormones by the gonads, the testicles and ovaries. So these hormones will induce the production of testosterone as well as estrogen. And so therefore, defects in the production of gonadotropins will result in infertility as well as erectile dysfunction. The next hormone is the adrenocorticotropic hormone, which is acting on the adrenal glands to increase the production of cortisol. And so cortisol is required for regulating metabolism as well as the blood pressure. So therefore, if there is a defect in the production of the ACTH, these patients present with low blood pressure, weight loss, as well as weakness. So you know how there is also this disorder called Addison's disease, where there is a primary adrenocortical insufficiency because the adrenal glands are not being able to produce the cortisol hormone. And so these patients also present with weight loss and low blood pressure. But in addition, patients with Addison's disease also present with hyperpigmentation. So could you explain why is it that defect in the ACTH itself doesn't cause hyperpigmentation, but then defect in the function of the adrenal cortex, which leads to the Addison's disease, causes hyperpigmentation? And the reason for that is that since now there is low level of cortisol, there would be a positive feedback on the anterior pituitary to increase the production of ACTH. And so ACTH itself is being produced by a precursor protein called pro-opiomelanocortin. And this pro-opiomelanocortin, in addition to ACTH, also produces the beta endorphin as well as the melanocyte stimulating hormone. And so with the Addison's disease, since there is now increased positive feedback to increase the level of ACTH, therefore the POMC in addition to ACTH will also continue to produce the endorphin and the melanocyte stimulating hormone. And so therefore the melanocyte stimulating hormone is the underlying cause of hyperpigmentation in patients with Addison's disease. On the other hand, if there is only a defect in the ACTH, since there won't be any more MSH that is being produced because there is now no positive feedback on POMC to break down, then that's the time that we only get low blood pressure and weight loss but no hyperpigmentation. Alright, now that we discussed the symptoms of the ACTH deficiency, next I would like to discuss the symptoms of the ACTH excess. And this will cause Cushing disease because now there is elevated levels of cortisol. And so these patients present with hypertension, obesity, moon faces, buffalo hump, stria on the abdomen. And since cortisol will cause weakening of the immune system, these patients can also have fungal infections. Other findings also include easy bruising, hyperpigmentation. So again, for the same reason, since there is an elevated level of ACTH production, POMC, which is giving rise to ACTH, is also producing the melanocyte stimulating hormone, and so that is the underlying cause of hyperpigmentation with the excess production of ACTH. And then finally, these patients can also present with hyperglycemia caused by the excess cortisol production. And then to summarize the findings, patients with Cushing disease, since there is an elevated level of ACTH production, ACTH will act on the adrenal cortex and increase the production of the cortisol. As a consequence of which, these patients can present in hypertension, and hypertension is seen due to the permissive effect of cortisol on epinephrine, and epinephrine will induce hypertension. These patients also present with hyperglycemia, and so therefore they're at increased risk of insulin resistance, and this is also partly attributed from the obesity. But then one other mechanism of cortisol-mediated hyperglycemia is from the permissive effects of cortisol on glucagon. as a consequence of which now there would be increased gluconeogenesis, and so now therefore there would be hyperglycemia. There is also increased amount of fatty acids that is inside the circulation, and so therefore there would be ectopic fat distribution that will result in, for instance, moon faces, an example of which is shown right here. So you can see how in this image the patient has moon faces, and this is from the obesity. And then these patients, in addition to moon faces, can have truncal obesity, as well as buffalo hump, where patients present with dorsocervical fat pad. Other findings seen with the cortisol is immune suppression, as a consequence of which there is an increased risk of fungal infections, particularly with Tinea versicolor. There is also thinning of the skin, as well as the easy bruisability, which is attributed to the loss of the subcutaneous connective tissue as well as the subcutaneous fat, as a consequence of which these patients can easily develop bruises upon injury. Other findings that are seen from a combination of skin changes as well as obesity is stria. In addition, patients with Cushing disease can also present with muscle wasting. Due to the catabolic effects of the cortisol, they can also present with acne, as well as male pattern hirsutism due to the elevated levels of androgen. So ACTH can also act on the adrenal cortex to increase the levels of androgen. And so therefore patients can present with acne and hirsutism. And then other findings include hyperpigmentation as well as osteoporosis, which is due to decreased absorption of calcium in the GI tract as well as decreased reabsorption of calcium in the kidneys. Now I would like to mention that so far I've discussed one of the mechanisms through which patients can present with Cushing syndrome, and that was Cushing's disease, where there was pituitary hyperfunctioning, as a consequence of which there was elevated ACTH that caused elevated cortisol. Other causes of the Cushing syndrome include ectopic ACTH syndrome, which can be from small cell lung carcinoma that causes paraneoplastic syndrome, and so therefore it will again increase ACTH and increase ACTH to increase level of cortisol. There are adrenal tumors that directly increase the production of cortisol. And then finally, iatrogenic Cushing syndrome developed from excess cortisol administration. And then one other point I would like you to know is that for the adrenal tumors and iatrogenic Cushing's syndrome, since there is an elevated level of cortisol, there would be negative feedback on the pituitary gland to decrease the production of ACTH. So with these two conditions, there is a decreased level of ACTH, while with the first two, there was an elevated level of ACTH. And then as for the diagnosis of the Cushing syndrome, you can order 24-hour urine cortisol levels. You can check for evening salivary cortisol, or you can check with the overnight low dose dexamethasone test, and then check the morning level of the cortisol. And if it's high, then it's confirming the diagnosis of the Cushing syndrome. And then from here on, to narrow down the diagnosis of the Cushing syndrome, which of the types we are dealing with, you order the level of ACTH. So if the ACTH is low, then we are either dealing with an adrenal tumor or with the exogenous administration of the corticosteroids. And if the ACTH is high, then we are dealing with either Cushing's disease or ectopic ACTH syndrome. So if it's high, then we are dealing with either Cushing disease or ectopic ACTH syndrome. And could you tell me how we can differentiate these two from each other? There is one other test that you can order from here on to help distinguish these two. And the test that you can order is called high dose dexamethasone suppression test. So high-dose dexamethasone would be able to act on the pituitary gland and suppress the pituitary gland, as a consequence of which there would be decreased level of cortisol production. So high-dose dexamethasone would be able to suppress cortisol in patients with Cushing disease. But then the ectopic tumor would be unresponsive to the dexamethasone because they don't have the receptors required to be suppressed negatively by the excess dexamethasone. And so therefore, if the patient has ectopic ACTH, the level of cortisol does not drop by administration of high-dose dexamethasone. Alright, now that we are done with the ACTH, next we can move on to the function of the thyroid stimulating hormone. So thyroid stimulating hormone acts on the thyroid gland to increase the production of the triiodothyronine as well as the thyroxine. So therefore, patients that lack the thyroid stimulating hormone will present with the cold, intolerance, weight gain, lethargy, constipation, and dry skin. And so you know how thyroid hormone is required for heat production, so it's not a surprise that if there is a defect in the TSH, these patients present with cold intolerance, and since there is now lower metabolism of the body, they would have weight gain and lethargy as well. And so the way I memorize that the cold intolerance is associated with constipation, it makes me think that their body is so cold that their feces will become so hard that they can no longer exit the body. So patients with TSH deficiency will present with cold intolerance and constipation. On the other hand, excess level of the TSH production will cause hyperthyroidism, which presents with the heat, intolerance. Since now that there is an hypermetabolism, they present with weight loss, and then they also present with diarrhea and moist, oily skin. And so again, the way I associate diarrhea with the heat intolerance is that patients with hyperthyroidism, their body is so hot that their feces will melt in the form of diarrhea. So again, now you know that hyperthyroidism is associated with heat intolerance as well as diarrhea. Alright, now that we are done with the discussion of the hormones that are being produced by the basophilic cells of the anterior pituitary gland, next we can move on to the hormones that are being produced by the acidophilic cells of the anterior pituitary. So the first hormone is the somatotropin, also known as the growth hormone, which is required for the bone and muscle growth. So defect in the somatotropin will result in dwarfism. And so in order to treat these patients, you will have to provide them with the somatotropin supplements. On the other hand, overproduction of somatotropin can cause gigantism, and this is on the condition where there is still no fusion of the growth plate. So before fusion of the growth plate. And so these patients can have a height as high as 9 feet. Since their growth plates are not yet closed, therefore they are able to grow as high as 9 feet. And then the next condition that can arise from excess growth hormone is acromegaly. And this condition develops if there is already fusion of the growth plate. So after fusion of growth plate, if there is excess growth hormone production, patients present with acromegaly where they would have enlarged hands, jaw, and feet. But since their growth plate has already fused, therefore they won't have high height. They would have a normal height, but then there would be enlargement of their hands and feet. And so for the treatment of patients with the acromegaly as well as gigantism, you will have to provide them with the octreotide, which is a somatostatin analog, and thus it will inhibit the function of the growth hormone. The next hormone is the prolactin, which acts on the mammary glands to increase the milk production. So patients that lack prolactin will present with lack of milk production. Next, we are discussing prolactinoma, which is the most common form of the pituitary adenoma. And as I just discussed earlier with you, the pituitary gland is in a close proximity to the optic chiasma. Therefore, pituitary adenoma can impinge on the optic chiasm and cause visual problems. And the type of the visual defect that you see in these patients is called bitemporal hemianopia, where you can see that the temporal sides has gone blind in these patients. And the reason for that is that since the pituitary gland is now impinging on the optic chiasm, so you can see that the medial parts of retina has gone dysfunctional. And the medial parts of the retina is required for the observation of the lateral vision. So therefore, patients with the pituitary adenoma present with the bitemporal hemianopia. In addition, due to the excess production of the prolactin, they present with amenorrhea, galactorrhea, where there is a milky nipple discharge unrelated to pregnancy and breastfeeding, low sexual interest, infertility, because prolactin prevents ovulation due to the decreased gonadotropin releasing hormone, and then bitemporal hemianopia is another feature that I've discussed with you. And so for the treatment of patients that have prolactinoma, you will have to provide them with the dopamine agonists, like for instance cabergoline or bromocriptine, which, as I just discussed, are dopamine agonists. And the way I memorize it is that you know how prolactinoma causes galactorrhea or milk production. So bromocriptine makes me think of clip the bra. So crip or clip, bro for bra. So you clip the bra so that the patients can no longer produce any more milks. So bromocriptine, which is a dopamine agonist, can be used for the treatment of patients with prolactinoma. The next hormone is the antidiuretic hormone, which is being produced by the posterior pituitary gland. So now that we are done with both the basophilic as well as acetylophilic cells of the anterior pituitary, next I would like to move on to the posterior pituitary gland. So the first hormone is antidiuretic hormone, also known as vasopressin. And the function of this hormone, which is being produced by the supraoptic nucleus, is to act on the kidney in order to insert the aquaporin channels into the principal cells at the lumen of the collecting duct, as a consequence of which now there would be increased permeability to water, and so therefore now there would be increased water reabsorption. So if someone is being dehydrated, at that moment there would be an elevated level of ADH in order to increase the reabsorption of water. And so one memory aid that I have for you to remember that is the supraoptic nucleus that is producing the antidiuretic hormone is that you look into the sky for rain. So look into the sky, you're looking above your head. Should remind you of the supraoptic above your head. And then rain should make you think of the antidiuretic hormone. So once again, the antidiuretic hormone is being produced by the supraoptic nucleus in the hypothalamus. And then via the neurophysin transporter proteins, this hormone is being transported to the posterior pituitary gland. And then in terms of the clinical presentations, patients that have low level of antidiuretic hormone present with the central diabetes insipidus. So let me ask you a question. What's the difference between central and nephrogenic diabetes insipidus? So with the central diabetes insipidus, there is low production of the antidiuretic hormone. On the other hand, with nephrogenic diabetes insipidus, there is a normal production of antidiuretic hormone, but then the kidneys are unresponsive to the antidiuretic hormone. And then lithium, which is a medication that is used for the treatment of bipolar disease is one classic example of a drug that can cause nephrogenic diabetes insipidus. In any case, patients with central diabetes insipidus, since there is now low level of antidiuretic hormone, will have polyuria as well as polydipsia. So these patients will have polyuria because they cannot reabsorb water, and so most of the water will now be excreted in the urine. So they have polyuria or excess urination. And so since they lose too much water, they would have polydipsia. So they would start to drink a lot of water. Other features that you will see is that hypernatremia. So since these patients lose a lot of water, concentration of salts in their serum will increase. And so they would have hypernatremia. On the other hand, since there is now too much water in the urine would be very diluted. And so you will have hypotonic urine with the central diabetes insipidus. Now, alternatively, if a patient has syndrome of inappropriate ADH, where there is an excess ADH production, you can see that now they would excessively reabsorb water, as a consequence of which it will cause fluid retention, hypertonic urine, because there is now not much water inside the urine, and then it will cause hyponatremia because now there is too much water in the serum, and so concentration of sodium, since there is too much water, will be dropping, and so this would cause hyponatremia. And then one other mechanism that will further enhance hyponatremia is that since there is now too much water, there would be a reflex decrease in the production of the aldosterone. And so now aldosterone, which is required for the reabsorption of salts, since the level is now too low, it would further enhance the hyponatremia in patients with SIADH. And so therefore, due to the hyponatremia, there is increased risk of seizure development. So for the treatment of patients that have SIADH, you should consider water restriction. And since these patients have hyponatremia, you should provide them with the salt oral tablets. In addition, you can consider providing demeclocycline, which prevents the function of ADH. In addition, you can also provide them with the lithium. So as we just discussed earlier, lithium is a drug that can cause nephrogenic diabetes insipidus. So patients that have too much ADH, if you provide them with the lithium, it will lower response of the kidneys to ADH, and so it will help resolve the symptoms. And then if the patient is having seizures, then that's the time that you will have to provide 3% IV saline. So once again, if the patient has seizure, then that's the time that you will have to proceed with the 3% IV saline. And so in patients with SIADH, the initial sodium concentration is almost all the time less than 120 milliequivalent per liter. And your goal is to correct for this hyponatremia no faster than 12 milliequivalent per liter. And so let me ask you a question. Why is it that you have to set your correction rate at less than 12 milliequivalent per liter in 24 hours? What happens if you go faster than that rate? Let's go you correct that for like 30 milliequivalent per liter in 24 hours. What is a complication that may arise in these patients? So there would be osmotic demyelination syndrome, the other name for which is the central pontine myelinolysis. So what happens when you correct for hyponatremia too quickly? The brain volume will drop too quickly, as a consequence of which there would be disruption of the blood-brain barrier, and so now there could be damage to the myelin sheaths. And so these patients present with the pontine myelinolysis syndrome, where there is a locked-in presentation. So these patients are generally awake but are unable to move or communicate due to the damage to the pons. Alright, so next I would like to discuss conditions that can lead to the presentation of SIADH. And one of these conditions is the use of the cyclophosphamide, which can act on the renal tubules and increase the water reabsorption. So one way I memorize it is that the demeclocycline makes the function of ADH to decline, decline, while the cyclophosphamide increases the risk of developing the SIADH. And then the other conditions that can cause SIADH include for instance, the CNS disease, as a result of which it will cause increase in the production of ADH. In addition, there are paraneoplastic syndromes like the small cell carcinoma of the lung that can increase the ADH production. So just to remind you, the paraneoplastic diseases of the lung, we can have the small cell carcinoma as well as the squamous cell carcinoma. So the small cell carcinoma itself increases the production of the ADH. So these patients can present with SIADH syndrome. It also increases the production of ACTH. So patients can present with the Cushing syndrome. And then it also produces antibodies against the presynaptic calcium channels in the neuromuscular junction. So therefore, patients can present with the Lambert's-Eaton syndrome, where these patients present with a muscle weakness that improves with repeated activity. And then the other paraneoplastic syndrome is from the squamous cell carcinoma of the lung, where there would be an elevated parathyroid hormone related peptide production, as a consequence of which patients present with hypercalcemia. Alright, now that we are done with the discussion of the ADH, the last hormone is oxytocin, and as I just discussed earlier, this hormone will act on the uterus to increase contraction and will act on the breast myoepithelial cells to increase the secretion of the milk. And the oxytocin is being produced by the paraventricular nucleus of the hypothalamus. Now that we are done with the discussion of every one of these hormones, it would be very easy to review every one of these hormones and the syndromes that produce. So the pituitary gland, if there is a hyperfunctioning of the posterior pituitary, you know the posterior pituitary is producing ADH as well as oxytocin. So the overproduction of the ADH will lead to the development of the SIADH. Anterior pituitary, on the other hand, if there is hyperfunctioning, if there is increased prolactin production, patients present with prolactinoma, which you may recall that the symptoms were like, for instance, infertility, decreased libido, galactorrhea, as well as the bitemporal hemianopia. If there is increased production of the somatotropin or the growth hormone, if it's before the closure of the growth plates, then patients present with gigantism, but if there is after the closure of the growth plate, then patients present with the acromegaly. And then if there is an elevated production of the ACTH, then patients present with the Cushing disease. If there is a hypofunctioning of the posterior pituitary gland, so posterior pituitary is again producing ADH. If there is hypofunctioning, patients present with central diabetes insipidus. And then finally, there could be a hypofunctioning of the pituitary gland from Sheehan syndrome and empty sella syndrome. And I haven't discussed these two syndromes with you, so let's discuss those in a little more detail, and then we'll be done with the discussion of this video. So the first condition is Sheehan syndrome, which is due to the postpartum hemorrhagic infarction of the pituitary gland. So after the mother gives birth to a child, if there is too much bleeding, then there would be decreased blood supply to the pituitary gland from excessive bleeding, as a consequence of which patients will have infarction of their pituitary gland. So their pituitary cells will die. And so patients, due to the dysfunction of the pituitary gland, present with weight loss. And since now that there is low level of prolactin, they would also fail to produce milk for a few days that can be extended even up to a few weeks. And then the final condition is the empty sella syndrome, where due to the defect in the diaphragm of the sella, there would be CSF that will flow in and will cause enlargement of the sella, as a consequence of which now there would be atrophy of the pituitary gland. And so here is an image that shows you that there is a defect in the sella diaphragm, as a consequence of which cerebrospinal fluid can now flow into the sella and cause atrophy of the pituitary gland. And so for the treatment of these patients, what you will have to do is that you will have to provide substitute therapy with the corticosteroids, thyroxine, sex steroids, as well as the growth hormone. And that concludes our discussion of this video.